This is Hemang Panchal. Today we have a case of 2SL PCI of heavily calcified subtotal occluded coronary artery disease with orbital atherectomy for non-ST microinfarction. infarction. Disclosures none. HPI, we had an 88-year-old female who presented to the ER with atypical presentation of bilateral arm pain for last 4 days. The arm pain had been constant, about 1 to 5 out of 10 intensity. It gradually became worse and did not go away, and therefore patient arrived to the ER. On arrival to the ER, she got sublingual nitroglycerin, which resolved her arm pain. Initial troponin was 15. She had an EKG done on previous admission, which showed normal sinus rhythm, no acute ischemic changes. On this admission, the EKG showed significant diffuse ST depression, and there is minimal less than a millimeter ST elevation in lead V2. Patient was asymptomatic after she got sublingual nitroglycerin in the ER. EKG did not meet any criteria for STEMI. Patient presented in the late evening. Therefore, we decided to pursue coronary angiography next day morning. Overnight, her troponin trended up to 33. This is the first angiogram picture. We got 6 French sheets in the groin. She's short lady, and therefore we decided to go groin rather than right radial. And I personally don't like left radial due to it's hard on my back and it is associated with high radiation for me. So the angiogram shows that there is subtotally occluded mid LAD, there is subtotally occluded proximal ramus intermedius, and there is subtotally occluded very distal OM branch, which is a small vessel and very tortuous beyond the occlusion. It's a left dominant system. The RCA was non-dominant. Here on this shot, you can see the ramus intermedius, which is 99% stenosed. All the vessels are heavily calcified. I used XB guide 6 French, and this is the first shot after the guide engagement. After that, I basically used the turnpike LP, passed the workhorse wire using the turnpike LP across the lesion in the LAD. After that, I exchanged the workhorse wire with the Viper wire. I took out the turnpike LP. I performed the orbital atherectomy of the mid LAD lesion. Unfortunately, I don't have the images of atherectomy. I did not save them. After the atherectomy, I again used the turnpike LP to exchange the Viper wire to the workhorse wire. I had total 3 runs of orbital atherectomy, and I usually do orbital atherectomy at 80k RPM. I usually do not use 120k RPM because that has been associated with high rate of perforation. This is the first shot after the orbital atherectomy, and you can see that the channel opened up a little more. As I mentioned in my previous videos, the goal for the orbital atherectomy is not to obtain luminal gain. The goal is to crack the calcium so we can have balloon inflation and good expansion of the stent. After the orbital atherectomy, I used 2.5 by 12 millimeter compliant balloon, and you can see it inflated pretty well. This is the shot after the balloon inflation. Following that, I deployed 2.5 by 23 millimeter regulating stent, which is well inflated. And following that, I used 3.0 by 8 millimeter NC balloon, and I inflated at high atmosphere to post dilate the stent. This is the angiogram after the post dilation of the stent, you can see there is an aneurysmal segment in the middle of the stent. I could post dilate that little more. The issue is sometimes when you post dilate more in a calcified vessel, you are risking for perforation. So therefore I just left it alone. Otherwise stent looks very well opposed. Proximally there is mild disease all the way up to the ostium of the LED, and I just left it alone. Then I wired the ramus intermediates using the workhorse wire. This was a bit tricky because of the angulation of the ramus intermediates. I pre-dilated the lesion using 2.0 by 12 millimeter compliant balloon, both distally and proximally. This is the angiogram after the balloon angioplasty. Then I deployed the 2.25 by 33 millimeter drug-eluting stent. This is the angiogram after the stent deployment. I post-dilated proximal segment of the stent, and this is the final angiogram, and you can see it's well inflated and well opposed stent in the ramus. We decided to leave the distal OM lesion for medical management. I already had 2 SL PCI in an 88-year-old lady who is at risk of developing contrast-induced nephropathy for multivessel PCI in the same setting. And it's a small vessel, very tortuous vessel. I saw the patient outpatient. Patient did not have any symptoms of angina or angina equivalent, and therefore I just left it alone for medical management. The echocardiogram performed during this non-STEMI episode shows significant regional wall motion abnormality. You can see that the anterior anteroseptal and anterolateral walls don't move much, and the EF is about 20-25%. Optimized hermetical therapy. Patient had an echocardiogram done after 3 months of PCI. The EF returned back to 55-60% with grade 1 diastolic dysfunction, and right ventricular systolic pressure was 47 mmHg. Thank you. Please feel free to leave any comment or question